All right, we're going to be starting off here with Allen's test. In order to do this, I'm going to have my patient sitting or standing. I'm going to put them in 90 degrees of abduction and external rotation with the elbow at 90 degrees of flexion. I'm going to be grabbing the patient, supporting up under their elbow, feeling their radial pulse. Once I feel their radial pulse, I'm going to have them look away, seeing if there's any diminishment of that pulse. A diminishment or absent radial pulse is indicative of thoracic outlet syndrome. All right, the next test I'm going to be doing is the Tinel stress test. In order to do this, I'm going to have my patient have their arm. It's going to be about 90 degrees. And I'm going to be putting just overall stress through the overall wrist. So in order to do this, I'm going to be going down to the first digit or second digit. I'm going to be putting an extension force on there and just seeing if that is provocating of any signs or symptoms. And if there was any provocation of signs or symptoms, that would be a positive for the Tinel stress test. All right, the next test we're going to be doing is the first MCP valgus stress test. I'm going to have my patient's first digit. I'm going to be supporting them. I'm going to stabilize at the MCP joint. Once I find the MCP joint, I'm going to be stabilizing right there. I'm going to be putting that valgus force on it. Kind of hard to see, but I'm going to be giving it that valgus force. And that's putting stress on the UCL of that joint. With laxity or pain, that's indicative of a tear with that ligament. So, or I'm also testing the end feel with that. So, was there any pain? All right, that would be a negative for this test, please. All right, so for the next test, I'm going to be doing the Tinel Sign. I'm going to be having my patient, they'd be on a flat surface. I'm just going to be stabilizing them, and I'm going to be tapping on the volar aspect of the patient's wrist over the area of the carpal tunnel. This patient would have complaints of tingling, paresthesia, or pain on the area of the thumb, index finger, middle finger, and radial one half of the ring finger. It would signal a positive test with that, and this may be indicative of compression of the median nerve of the carpal tunnel or carpal tunnel syndrome. All right, the next test I'm going to do is Phelan's test. The patient is going to be sitting or standing with the dorsal aspect of both hands in full contact so that both wrists are maximally flexed. A steady compressive force is applied through the patient's forearm so that the patient's wrists are maximally flexed for 1 minute. This might not be long enough if the patient is in position longer. You can or it does not work through that. You could have it go longer, but that can go a long time. A positive would be numbness and tingling in the median nerve distribution of the fingers. This would be the thumb, index finger, and middle finger, and lateral aspect of the ring finger. This would be indicative of a carpal tunnel syndrome secondary to median nerve compression. The next test I'm going to do is Finkelsteins Test. This is a test that's kind of checking for Decker veins. And in order to do this test, I'm going to have my patient take his thumb, put it into maximal flexion going down, and then he can close his fingers around. And then with that, I'm going to be stabilizing around on like the distal forearm, and be bringing it down into passively into ulnar deviation. And I'm going to be looking for pain with that. Pain over the abductor pollicis longus and extensor pollicis brevis tendon distally is indicative of tenosynovitis of the tendons, indicating the Decker veins. All right, the next test I'm going to do is the Litner test. I'm going to have my patient with the MCP joint of the involved digit in slight extension. And so I'm going to have that MCP in slight extension. So I'm going to passively flex the PIP joint of the same finger that I'm assessing, and I'm going to measure the amount. Okay, the next part that I'm going to do is then passively flex the MCP joint slightly, and then I'm going to be passively flexing the again on the PIP, measuring that as well. A positive finding is that revealed if the PIP joint does not flex while the MCP joint is in an extended position. If the PIP joint does fully flex once the MCP joint is slightly flexed, intrinsic muscle tightness can be assumed. By contrast, if flexion of the PIP joint remains limited once the MCP joint is slightly flexed, capsular tightness can be assumed. This is just a good way to overall measure if there is the extrinsic tightness. All right, the next test I'm going to do is the oblique retinocular ligament test. I'm going to have my patient sitting. They can have their arm resting on the table. I'm going to passively extend the PIP joint while I flex the DIP. Or I'm going to have them flex the DIP, and I'm going to measure that. The next part is to go down, and I'm going to let them flex the PIP and the DIP, and then I will measure the DIP again. This tests for the lack of DIP flexion and determines if the oblique retinocular ligament or joint capsule tightness is there. Increased flexion indicates oblique retinocular ligament, whereas no change would indicate joint capsule. All right, the next test I'm going to be doing is Finkelsteins Sign. In order to do this, I'm going to have my patient grab the sheet of paper. They're instructed to hold it between the thumb and index finger. I will then try to pull the paper out. A flexion of the patient's DIP joint of the thumb is indicative of the adductor pollicis muscle paralysis due to ulnar nerve damage or lesion. Patient won't be able to keep their fingers pad to pad. They will switch to tip to tip. All right, the next test I'm going to be doing is the anterior interosseous nerve test. I'm going to be testing the integrity of the anterior interosseous nerve, which is the motor part, and it's a branch of the median nerve. In order to do this, I will have the patient make the OK sign with their index and thumb finger. A positive test is when they go pad to pad instead of tip to tip. This indicates the flexor pollicis longus and flexor digitorum pollicis are injured or paralyzed. All right, the next test I'm going to be doing is the Watson scaphoid test. In order to do this, I'm going to feel my patient going over for the scaphoid, palpating once I find the scaphoid. I'm going to put a little bit of the volar force on there, and then I'm going to be palpating both ulnar and radial, feeling as I go radial, it'll come out, whereas ulnar, it'll go back in. This is normal movement, but if there were any differences outside of that, this would be pathology of the scaphoid, signifying that there's hypermobility from the scaphoid.